Dr. Wibbenmyer is currently the medical director of the Burn Treatment Center and the Burn Fellowship Director at the University of Iowa Hospitals and Clinics. And Dr. Wibbenmyer recently served as the president of the ABA, and we are really happy to have you speaking today on disparities in health equity and burn care.
Thank you. I'm very happy to be here and to have burn included in this conference. So thank you for inviting me. I have no conflicts and my disclosures are listed. My objectives are first to review disparities in burn care, and then I will turn to research initiatives that offer promise in health equity in burn prevention, access to health care, and recovery and reintegration of our burn survivors. So first, let's review current disparities in burn care. These disparities can be conceptualized into 5 different areas. These areas, while separate, affect each other and are overlapping. I'll briefly touch on each one, and then I'll go into detail on 3 of them. The first area that leads to an inequitable burn care involves upstream factors, AKA social determinants of health. In burn care, this affects the incidence of burn injury. It affects the ability to access burn care. The second factor that leads to this inequitable burn care involves patient factors. Socioeconomic status, people who are lower socioeconomic status actually have impaired access to burn care. Historically marginalized people often have more comorbidities, and these affect outcomes from their burn injuries. They lead to more complications and more mortality. People who speak English as a second language have problems with follow-up and accessing high-quality care. The cultural differences we intersect with in burn care are a lack of acceptance of mental health, wound care preferences, and often the decision-making that involves communities or families or elders. Next slide, please. Provider factors that lead to inequitable care are really no different than the other provider factors we find in other surgical specialties, so I won't belabor these. Quality factors involve access to care, but also people who are historically marginalized, as I've said before, have more morbidity and more mortality from their burn injuries. And finally, recovery or reintegration is so important to our survivors. Burn care is neither complete or successful unless we can get people back to their quality lives. And to do that, we have to address all these factors that are listed on this slide. Now, all this talk about disparities is heavy and depressing, but what I think is energizing and gives us agency is the ability to talk about solutions. So for the next part of this talk, I'm going to talk about solutions in 3 areas. So I'm going to focus on prevention, treatment, and recovery. All these areas have studies that have led to some success in decreasing disparities in burn care. These studies have been small, but they may be scalable to offer real solutions. The first is prevention. While burn injuries have decreased in numbers, there remains a persistent gap for Black people. Black people are 66% more likely to report to the emergency room with burn injuries. They are 75% more likely than other races and ethnicities to present with burn injuries. This is also true for children suffering burns in the home. Children of color, except for Hispanics, are more likely to have burn scalds in their home environment. Black children in particular are 3 times more likely. And those who don't have insurance, of which Native Americans constitute the largest group, are 6 times more likely to suffer these scalds at home. We've known for a long time that social determinants of health lead to burn injuries. So it's not simply, race and ethnicity does not simply paint the picture here. Exciting new technology, which I'm really excited to hear about later on, involving geographic information systems, integrates the physical world and the social environment, and it helps pinpoint areas that are hotspots for injuries. Jennings used geographic information systems and was able to predict fires in Memphis with an accuracy of about 83%. So this technology may offer an opportunity to use scarce prevention research dollars. Community-level projects have also been successful. This Cochrane review reported on 39 studies that looked at community interventions to decrease scalds in children. 4 studies met inclusion criteria, and that criteria involved that they measured the outcome variables. 2 of those studies actually showed a decrease in injury rates. The first study, performed in Israel, was a multifaceted campaign. The second study, performed in Norway, focused only on scalds, and they showed an amazing reduction that was sustained for 7 to 10 years after the study. Lessons learned from these community interventions involving multiple stakeholders, careful planning, using sound methodology. But still, there is a gap in what we know works in implementing that. Second area I wanted to focus on was access. Regionalization of burn centers has been present since the early 2000s. There's no argument that we need to have regionalization of these centers. Burn care is very resource intensive. However, this has created a bottleneck in access. About 50 to 75% of burn injuries never see a verified burn center. The map on the left shows lack of access to verified burn centers in red. The map on the right shows somewhat better access when you consider non-verified burn centers. Telemedicine, telehealth, has created inroads in improving health equity in many fields of medicine. This may offer a solution here. There are over 40,000 apps for healthcare available currently. As of 2015, there were 77 available for burn care, and most of those were directed at the provider level. Burn care is no stranger to telehealth. Because we are regionalized, we serve a large catchment area usually. This is the center of Utah at the target, and you can see their catchment area extends several states. They published in 2009 the results of using telemedicine with video in its ability to be accurate in predicting injury and decreasing the need for air transport by an amazing 60%. This study was updated recently by Carmichael and colleagues. They used a smartphone app, a HIPAA-compliant smartphone app, to evaluate the need to transfer burn patients to their center. And what they were able to show in a subgroup of patients with burns less than 10%, and that's important because that group may not need urgent transfer. They were able to show that they downgraded the need to transfer or the ability to transfer by private car by 33%. This also extends to follow-up care. In a very small study, but intriguing, Garcia and colleagues showed that parents of burned children were able to successfully use a recovery app to guide them through wound care. He showed that they had shortened time to healing and significantly less return clinic visits. What I find intriguing and somewhat scary is the amount that this app was accessed by the parents. They generated 529 messages to the clinic staff. The good news is that 40% of those messages did not require an answer. So how do we move the needle forward? Well, we see that telehealth can expand access to expert help. It can save costs. However, to be successful, there are many factors that need to be in place. We need to have stakeholder development, we need to have support, and we need to have buy-in. The final area I wanted to cover is recovery opportunities for our burn patients. We've talked a lot about recovery and what happens after our patients leave the hospital. This is important for trauma patients, it's important for burn patients, it's important for all surgical patients. Returning to work is very important for most adults. It gives them a sense of identity, socialization, and financial income. But there's many factors that impair our survivors' ability to return to work. They're listed here, but I want to highlight a few. Female sex, government insurance, and age are some of the barriers we see. Power and colleagues in Seattle performed a study where they instituted a multi-pronged approach to getting their patients back to work. With this approach, they had a success rate of about 93%, pretty amazing, at getting patients back to work who were previously employed. What they found was that a third of them needed accommodations. So I think that's important. And what they found in the non-returners were most of them had functional limitations and or they worked in the construction industry. So we know that functional limitations can be a barrier back to return to work. Inpatient rehab after acute discharge is critical to jumpstarting mobility. And you can see from this graph, on the y-axis, we have discharge to rehab. On the left axis, we see that it varies up to 6-fold based on the state you're discharged from. And if you lack insurance or you're underinsured, you're 75% less likely to be discharged to inpatient rehab. And this is important because studies that have looked at the deprivation community index shows that those patients who come from areas that are underprivileged, underserved, have more barriers to achieving successful reintegration. And inpatient rehab works. Patients who attended inpatient rehab were 9 times more likely to return to work, and they had functional gains. So how do we move the needle forward? How do we get more of our patients discharged to inpatient rehab? It's a daunting task. A small study looked at the role of standardizing discharge criteria, trying to pinpoint people who would benefit the most. Maybe we need to institute a PMR consult or vocational rehab, such as they did in Seattle. And I want to challenge inpatient rehab to look at more tangible outcomes. And finally, reintegration of survivors involves more than just returning to work. It involves returning to family and social activities. People of color lag behind white people in terms of reintegration back into their communities. And then when you look at the sexes, there are also differences here. Burn females have a higher rate of home integration compared to community females. However, when you look at social integration, both burn males and burn females lag behind their community counterparts. In burn males are significantly lower. And both burn males and burn females are significantly lower in returning to productivity than their community counterparts. So there's many factors that are involved here in reintegration and recovery of our burn survivors, but there's several common themes. An intriguing app is the Bridge app. This app was developed with 3 focus groups, and it provides burn education, links to biophysical, biopsychosocial information, and cognitive behavioral messaging to help survivors through that recovery process. And I'll just say that that Bridge app is just starting to be evaluated in a multi-institutional study. Guess I'm done. I want to thank everyone for your attention.